Hello, this is Dr. Eduardo D'Alessandro from Brazil, and this is a video comment for our 16th week of the PPCR 2021. This week we've been discussing non-inferiority trials and the case of Professor Daniel Perkins from Canada, who submitted a manuscript to The Lancet and has just received a reply from the reviewers. The trial was a large, multi-centered phase 3 study aiming to prove the non-inferiority of a new anticoagulant versus heparin during percutaneous coronary intervention (PCI) on subjects presenting moderate to high-risk acute coronary syndrome. The primary outcome? 30-day composite ischemia, death, myocardial infarction, and unplanned revascularization. Well, the reviewers present a few questions. Was the non-inferiority design the best choice? How can you prove that the new drug is actually better than placebo? And does respecting the selected margin really stands for non-inferiority? To address these questions, first we must define non-inferiority trial. This type of design aims to prove that the effects of a new intervention are not inferior than the standard interventions up to a certain point. This certain point is known as the non-inferiority margin, and it represents the loss of effect that wouldn't be clinically relevant, or the loss that could be accepted by the patients given the new intervention brings along less side effects, lower dosing regimens, or other benefits when compared to the standard intervention. How to establish an adequate margin is always a matter of debate, and the reviewers claim that the chosen margin was too large, implying that the proposed non-inferiority could be false. Well, this could be addressed by establishing a tighter margin based on historical data of heparin effect size on the prevention of thromboembolic events. And we would define the non-inferiority margin at a fixed point, like 50% of such estimate. As for the question about the selection of the non-inferiority design and the question about excelling placebo, they both bring the discussion to ethical and practical aspects. For heparin is the standard intervention to prevent thromboembolic events related to PCI. So designing a superiority trial of the new intervention versus placebo wouldn't be feasible due to ethical constraints. One could plan a superiority trial comparing the new intervention against heparin, but this would deviate from the primary research question that was, does the new drug present a similar thromboembolic event preventing effect as heparin while bearing less side effects? So a superiority trial would be searching for differences between the two interventions regarding to the events, the thromboembolic events. Since heparin has a large size effect, it is expected that its effect size won't be surpassed by the new intervention. But the new intervention could be useful if it proves to retain some of the heparin effect while bearing lesser side effects. Hey, thanks for watching. See you next week. Bye-bye.